welcome for this year's academic program of ISHK, our new president, Dr. Pradeep Bhosale, and new chair members, Dr. Krishna Kiran and Dr. Kumar. They will now regularly do the academic programs which we are doing. This year, in the first program, they put in a lot of efforts and put in all stalwarts for this first lecture. Dr. Gurava Reddy has joined from US. And you see the list of the speakers who are for this, and this is going to be the program like before. A small change instead Saturday. We want to do it this on Thursday, and instead of o'clock, we are going to start at 8, making it convenient for the middle part of the week, and it be convenient to everybody for the new committee and everyone agreed. With this, I hand over to Dr. P. Ashok, the new education chair member, along with Krishna Kiran, and he will brief you about what is the whole of this lecture, what plan, and after that I will continue with the program. Over to Ashok.
Good evening, sir. I'm audible? Thanks for the ISHK giving this opportunity.
Yes.
And I especially thanks Gurava sir. I want him to be the opening batsman. I call middle Parapatellar, install of what we learn. And my senior colleague Krishna Kiran and other Anil, all my colleagues, Pradeep sir, thanks for having, since it's an academic program of FNB and DNB, we need to have something different this time. We have every month a different series. So that's why I need an opening batsman, Gurava sir, to has the best. With blessings, we'll open this series from now. Without wasting time, Gurava sir, over to you.
Yeah, thank you, Ashok and others. It's a great privilege to be here. You all know that all the group which has joined has got a great passion for teaching. And I think teaching is the best way to learn. And I always say that a surgeon's life is in 4 decades. The first decade is learning. The second decade is earning. The third decade is teaching. And fourth decade is giving. So I am in the cross section of the third and fourth decades. So it's nice to see you there. And so we will start from the basic medial parapatellar approach, which is every arthroplasty surgeon will know about that. But having said that, I could not learn, in spite of my longing, the Subvastus approach, which Nilen is a pioneer. I request all the youngsters who are embarking on arthroplasty journey should learn Subvastus approach. It's no doubt one of the best approach I have seen. Krishna Kiran also came and showed me in the theater. It's not a rocket science, learning Subvastus, but somehow I never got into that, but I appreciate the value of that. So today let us do the majority of the people do the medial parapatellar approach. There is nothing much to teach you, but just let us go back and see the relevant anatomy. We all know that quadriceps is a 4-layered muscle, and we will go between vastus medialis and rectus femoris, that is incision. And you can see the anatomy. We go between rectus, vastus medialis and rectus femoris, and femoral artery and vein, sciatic nerve, you all know that, and I don't need to tell you about that. The important thing is that the relevant anatomy, the blood supply to the skin must be respected. Very important point. You got to appreciate that the blood vessels perforate the deep fascia and form an anastomosis superficial to the deep fascia. So that is a very key anatomical point which has got a lot of clinical relevance. The dissection should be deep to the fascia to maintain good blood supply to the skin. That is the important point. And again, unexplained anterior knee pain following TCAR was reported in 33% and 10% of all patients. AVN of the patella is iatrogenic disruption of the patellar artery supply during the TCAR has been identified as a possible contributing factor to 60% of the commonly reported patellofemoral symptoms. So be careful about that. So, and again, lateral release performed to correct patellar maltracking can cause AVN of patella. So lateral release has to be done sometimes if the patellar maltracking is there. But having said that, nowadays with the good patella tracking implant, there is no need for lateral release. And in fact, with Subvastus, we never release patella, lateral release at all. So that is the important point. And you can see that there are arterial supply to the patella, lateral superior genicular artery, lateral inferior, medial superior, medial inferior, and all these arteries contribute to the patellar blood supply. Now, standard surgical approaches, medial parapatellar, subvastus, midvastus, and lateral. The other speakers are masters of that, and they will teach you. Today, we will go with the medial parapatellar approach. It is the most commonly used, is an anterior midline incision, obviously. If the midline skin incision is moved medially, it will be parallel to Langer's cleavage lines and subject to less tension and better healing. Some people can go even up to the medial border of the patella, whole incision also I have seen that. But I prefer to go midline, curve it around the patella. The blood supply to the skin covering the anterior knee arises mainly from the medial side. So medial skin incisions risk creating a large lateral skin flap that may be poorly perfused. So one important point for the youngsters is never lift the lateral side of the flap at all. All your work is on the medial side. Lateral side, whatever is the skin deep fascia cut attaching to the deep fascia should not be dissected at all. So that is the important point, and that is a pictorial representation. And now, if multiple previous incisions are present, the most lateral usable incision should be selected. Remember, lateral is lovely. So that's a simple mnemonic. So always take the lateral incision if the multiple incisions are there. Cutaneous blood supply may be compromised in case of previous surgery or poor host, and hence more liberal incision should be used. And again, gone those days where a minimal incision and those sort of things are gone. Now the big surgeons make big incisions. That adage has come back. So give a liberal incision. Don't create tension at the end of the skin that will lead to the necrosis. You can see that, and those are the multiple. Old incision should ideally be crossed at 90 degrees if you got a old incision. If previous parallel longitudinal incisions are present, a skin bridge of 5 to 6 centimeters is recommended. Skin under appropriate tension takes the shape of letter V, not U. That is an important point. So cut the skin longer so that the necrosis at the edges is not there. Now, this is bony landmarks, marking flexion, patella, tibial tuberosity. A lot of people do that. I don't do that nowadays, but still it is a good habit to make a marker pen or methylene blue and make a skin incisions, at least in the first 5 years of your career. Okay. And longitudinal slight incision is marked extending from 5 to 8 centimeters above the superior pole of the patella to below medial to tibial tuberosity. 1 centimeter medial to tibial tuberosity is very important. You should never cut skin on the tibial tuberosity, please, because that will cause a painful neuroma and patient feels very, very bad about it. So always avoid a prominent tibial tuberosity. Go 1 centimeter medial to that. And incision should be taken with knee inflection. Again, to allow the subcutaneous tissue to fall medially and laterally, which improves the exposure. And so that is a very important point, to give the knee flexion and do the incision. And again, closure also, better to flex the knee to 90 degrees and stitch it up. Now, nerve at risk is obviously infrapatellar saphenous nerve, and the symptoms pain due to neuroma formation and decreased sensation over medial knee. If it gets cut intra-op, reset it and bury it, and in the end, in fact, to decrease the chance of painful neuroma. So that is one technical point. And now, superficial dissection, you can see that my marks on the wound. Develop a medial skin flap to expose the quadriceps tendon, medial border of the patella and patellar tendon. First, what I do is first mark the patella, put a thumb medial to the patella so that the incision will be 1 thumb away. Never cut close to the patella. Again, another practical point, which is a very, very useful. If you cut close to the patella, there won't be enough flap to close it up. So always take a thumb as a landmark and cut thumb away from that. So then enter the joint by cutting the joint capsule by leaving a cuff of capsule tissue more than 10 millimeters. That is the important point. Medial to the patella, to facilitate the closure and preserve the blood supply. Arthrotomy incision ends 1 centimeter medial to the tibial tuberosity. These 2 points are very important take-home message. Thumb away from the medial part of the patella, and again thumb away or 1 centimeter away from the medial part of the tibial tuberosity. I usually start at the midline of the patella. First do the arthrotomy there, then I extend up and down. That is the better way to do it. Again, here you can see that this is a pictorial representation. Now, deep dissection, sublux the patella laterally, then flex the knee to 90 degrees. That's the important point. If the patella is not dislocated easily, extend the skin incision superiorly and inferiorly based on the tightness, split the quadriceps tendon accordingly. And again, for the youngsters, inversion of the patella is not mandatory for a knee replacement surgery. Simply, you can sometimes wear a fat knees, you can simply sublux the patella without everting the patella and put a cloud homans. That is more than enough. But never put it under tight tension. Don't try to evert the patella. Sometimes you will have a patellar tendon disruption, especially in rheumatoids. Be careful about that. Again, coming to the HOFA fat pad, HOFA fat pad should be excised only whatever is needed. You don't need to go and take off all the fat pad. Sometimes in rheumatoid knees, you should do that. But in arthritic, osteoarthritic knees, take it off whatever is needed to give you a good exposure. Same thing with the suprapatellar area also. Now I got a video here. I'll just see that because the patella is marked there, tibial tuberosity is marked there, and then again you make a circumference picture of the patella and then take the incision. Okay, and that's the vertical, and again cross marks to make it this one. And again, when you're doing this cutting knife, you must have seen the scalpel has got 2 ends. One is a apex end, one is a bottom end. You should cut the skin with the bottom end. Then what happens is with one stroke, you will cut more. Once you go inside, you should make the scalpel vertical. Then you will cut only with the tip. That is why the scalpel blade is designed like that. I hope you appreciate that. When you cut the skin, scalpel should be parallel to the skin. When you go into the deep tissue, it should be perpendicular to the inside of the tissue. So that is the important point. And let me see. You can see lateral side, I'm not touching at all. You should not touch it, erase it, always on the medial side. You can see the deep fascia going along with the skin and superficial fascia. It just peels off. You can just peel a beautiful layer. God has created this nicely for us to have a nice exposure. See, that is a vastus medialis. That is a tibial tuberosity. Now we can see that that is a rectus femoris. And now the patella, you can mark it again if you want. There is no harm or there is no what you call insult in making the marks even after working for 10, 20 years. It's always good to do that. Again, I'm marking the tibial tuberosity so that a very important point, your dissection should be going away from that marks, methylene blue marks. Okay. And now you can see that here, of course, I'm making the arthrotomy from the top. But usually I make it at the patellar level and extend it up and down. This also is fine, but again, you got to patella thumb away from this side and going there. So thumb away, again, you can put a methylene blue mark on the medial patellar area and then go for that. And so that's what it is. And that is arthrotomy, you got it. Okay. Now, simple advantages are very, very straightforward. It's the most common exposure, easy to learn and reproduce, and very good exposure of the joint for simple primary, complex primary, and revision TKR. Very easy dislocation and eversion of the patella, yielded excellent and reproducible results in long-term studies of the TKR. The so-called disadvantages are patellar avascular necrosis due to damage to the descending genital artery, superior medial and inferior medial genital vessels. It looks more theoretical than regular thing happening. I have not seen many patellar avascular necrosis in my lifetime. I am sure my other colleagues also concur with that. Patellar instability and maltracking can occur. This is again a point. Lateral release may be needed to correct it. That's why when people like Nilen do subvastus, you don't need to even see where the patella is going. It automatically falls where it belongs to. And delay in rehabilitation and post-op pain, and sometimes neuromas can happen if you are not diligent with your skin incision. So that is the nutshell of the medial parapatellar arthrotomy and the workhorse of the knee replacement surgery. Thank you so much for listening. And what is the pattern, Ashok? Is there any questions allowed, or we go to the next talk?
Yes, sir. We'll go to next talk, sir. Thanks for giving a beautiful lecture, sir. It's a good.
We have a nice time, my friends. We'll see you back. Bye-bye.
Yes, sir.
Thank you. Thank you, Gurava. Wonderful lecture.
Thank you.
So I learned from Gurava sir by medial parapatellar. After seeing Nilen sir, I started doing subvastus now. So over to Nilen sir.
Thank you. Can you hear me?
Yes, sir.
Yes, sir.
So let me just see. I think I had it here, and where is it gone? Okay. Okay, can you see? Can you all see it?
Yeah.
Yes, sir.
So firstly, thanks ISHKS for letting me present this. And I would say that the Subvastus approach is my passion. I started doing it since 2005. And since 2008, I'm doing it tunicaless. And the passion keeps on growing. And with Ashok, Kumar and Kiran and everybody also joining, I feel that this Subvastus movement is growing. And I would put it to you that it aids in early and in eventual recovery. But as Gurava said, it is still not mainstream. There is a perception that it does not offer any major advantage. It's a limited exposure, seems difficult and requires patient selection. Replacing the patella is difficult. So with all these things, why should one do it? But I put it to you that perceptions may be wrong. Subvastus has huge advantages. It is versatile, can be done for all comers. Patellar exposure can be consistent. There is a lot of literature support for its use, but one needs to have an open mind. When you change what you believe, you change what you do. It's not new. German literature described it more than 100 years ago. Hoffman in CORR described it in 1991 in English. I have used it more than now, I think 18,000 times, including revisions. And this is my approach, whether I am doing a primary knee, a revision knee, a uni knee, whatever I do, it's Subvastus. And I have been impressed by its physiological nature, versatility, patellar tracking, and low morbidity. And I'll just give you a few examples of what is possible. If anybody wants to see the actual video of the Subvastus approach, I have got videos on ViewMedi where I'm operating a knee, which is a valgus knee with Subvastus. I put a video even of a uni knee Subvastus on ViewMedi. So you all can see the actual videos there. And I'm just going to mention a few key points and what can be done. So what is the key point is that you take an adequate anterior incision, as Gurava said. No need to make it small. The incision needs to have a medial bias. You raise the medial flap just like Gurava did until the vastus medialis and VMO can be clearly seen. And then you do an inverted L capsulotomy, subluxate the patella in the lateral gutter, and then only flex the knee. So trochlear osteophytes can be removed. Then the knee is exposed in flexion. Femoral, tibial, and intercondylar osteophytes are removed. So the knee is debulked. So the key to Subvastus approach is that you would take one part at a time, address it, and then move to the other part. And you will take advantage of the mobility of the knee to expose different parts of the knee. So these are some different knees. And you can see that fairly deformed knees can also be operated through the Subvastus approach with gratifying results. So is the approach limited? So I'm now going to show you a non-TKR example. This is a 38-year-old lady who had PVNS. You can see the MRI scan and the extent of the disease. So here I have done a classical subvastus approach, tunicaless, adequate anterior incision, raise the vastus medialis and vastus medialis obliquus from the septum, divide the VMO attachment. You can see the PVNS which is exposed here. After excision of that, you can see the patella also completely exposed, and the medial gutter, the lateral gutter, circumferential exposure of the knee can be achieved by the subvastus approach, as can be seen here. And when you are closing, if you just put one stitch at the angle of the L where you have done the capsulotomy, everything just falls in place. So the capsulotomy is always closed anatomically, and you don't need to make any marks on the, the parapatellar area to see where you have taken them off. There are various supposed contraindications, and I have operated on all these patients with the, subvastus approach. But the contraindications are there in the Bible of knee surgery by the textbook of Insall and Scott. So here is a lady, some complex knee, varus knee with stress fracture. You can see the incision, the dissection, the post-op knee flexion, and the way this lady is walking after both the knees. Morbidly obese lady, again subvastus approach. So you can do this. And we published our results in the Indian Journal of Orthopaedics, and subsequently even published our midterm results in obese patients. Post-HTO, you can see this lady walking with a great amount of thrust and a medial defect on the tibia. This case was done by me more than maybe 30 years ago in Surat. The tibial defect was grafted. I took a separate incision for staple removal. You can see the tracking of the patella, which is an absolute non-issue. And this is the same 82-year-old lady walking at around 6 weeks post-surgery. Obese valgus. You can see the radiographs. Gross recurvatum. You can see the stability of the spacer on table. Note the eburnation of the lateral condyle after implantation of the components. And you see the result and the restoration of the alignment. A windswept deformity post-HTO, more complex case. A constrained implant was available, but I got away by just doing a CR knee for this complex deformity. So subvastus and valgus, as I said, is published, and I have even put a video on ViewMedi as to how to do that. Subvastus in stiff also is described, and I have a video ready, and I will show that on ViewMedi on one of these days. Previous operation, synovectomy, note the lateral incision. So you can do a subvastus through this. And in fact, my incision for the total knee has been lesser than the previous synovectomy incision, as can be seen. So resurfacing of the patella is still debatable. Minor patellar maltrackings are better tolerated if the patella is resurfaced, but subvastus can give you immaculate tracking, as can be seen. Perfectly aligned patellofemoral joints with the subvastus approach. If you take skyline views after all your total knees, you will find that a lot of patients have tilt when they are operated through the medial parapatellar approach, and some patients develop even a delayed tilt. In subvastus, these stabilizers remain intact. And here you can see that subvastus approach, the components are in and the patellar tracking is absolutely perfect. No thumb test, no reverse thumb test, nothing is required. If you want to resurface it, you can expose the patella and evert it after the femoral and tibial osteotomy. So resurfacing is more difficult, but possible. In revision also, one can do it. It has the same advantages. I'll quickly go through this. Somebody had done a bilateral unis. They failed in 2-3 years with heaviness, synovitis, and pain. And I did bilateral staged subvastus approach without tourniquet, cleared the gutters, removed all the metal debris, removed the components. Patella was subluxed, intercondylar and posterior clearance. You can see what has been done. And a standard PS component with patella was used, and the other knee was also operated. So this is the revision of a uni. And this person subsequently did well. So this is a revision of a total knee. Gradually increasing soft tissue swelling, 2 years since total knee, done elsewhere. And you can see the malalignment and polywear. So here we revised only the tibia through the subvastus approach. And this lady did well. And these are her subsequent x-rays and clinical result. A failed total knee due to medial condyle fracture. So here also I used the subvastus approach and femur was revised. But you can do a full revision through the subvastus approach also, as can be seen here. Failed total knee at 10 years, and I have put a custom implant through this approach. How proximal can we go? 10 to 12 centimeters. Beyond that, there is a risk of injury to vessels, descending genicular artery, femoral artery exiting the adductor canal. So you need to be careful. We have even published this way back in 2016. So my observation is that adequate exposure can be achieved in all knees. Lateral release is rare. Average blood loss is around 400 cc. Average hospital stay is 2 days. And average surgical time is around 30 to 40 minutes. Quadriceps recovery is early. Most people are able to do an SLR on the day of the surgery. They are walking on the day of the surgery, and they are able to go home the next day. They have a reciprocal gait by day 2 or 3, and ascending and descending stairs is also possible. 30% of the knees flex fully, and that happens because the patellar tracking is immaculate. And the flexion that you achieve is kinematically correct. That means there is good femoral rollback. Complications can occur. Infections, condylar fractures, ligament injury, vascular injury, tendon ruptures. 3 patients required a liner exchange. 1 patient had a malpositioned patellar prosthesis, aseptic loosening. But maximal complications occurred in the stiff knees. Stiffer the knee, the more difficult is the operation. Post-op bruising is common, as I don't use a tourniquet or a drain. It can be extensive, and patients need to be warned. So in conclusion, I will say that subvastus approach can offer a faster recovery, may help in achieving better flexion. Surgical technique is important. It is the approach of choice for practically all knees in my hands, and my passion continues and grows. I thank you for your attention.
Thank you, sir. It was elaborate, very crisp exposure about the subvastus, and I truly follow that also.
Ashok, there is a question for Nilen in the box.
Yes.
2 questions.
So how to improve the exposure if patellar eversion is not possible with the subvastus approach?
Yeah, the key thing is to mobilize the quadriceps properly. So you have to mobilize the quadriceps from the intermuscular septum. If the knee is stiff, you have to raise the vastus intermedius from the femur. Then you have to remove all the osteophytes that are present. And do not flex the knee until you can subluxate the patella in the lateral gutter in extension. Am I clear?
Yes, sir.
So the key thing is make the incision longer. elevate the quads from the intermuscular septum. If the suprapatellar pouch is thickened or if knee appears stiff, take a periosteum on the anterior surface of the femur and raise the vastus intermedius. Expose the femoral trochlea. If there are osteophytes, you remove it. If you do this, you'll be able to at least evert the patelline extension a little bit, remove the offending patellar osteophytes, then flex the knee gently. If there are prominent lateral osteophytes on the femur, remove those. Remove the intercondylar osteophytes, and then you'll have the exposure.
Hi, sir. Can I ask a question? Adarsh?
Please.
Nilen sir, hi. This is a simple question. What is the learning curve for somebody who's been doing parapatellar all their lives? And if they want to start doing this, how many cases does it take to get kind of proficient in it?
I think it is an all or none thing. You got to believe in it. If you believe in it, you will be proficient in 5 cases. If you don't believe in it and you feel that you are going to go back to the medial parapatellar approach, you'll never learn it.
Right, sir. So around 5 to 10 cases, if you are like completely tuned.
Yeah. See the videos properly, and I've really put really nice videos on ViewMedi.
Yes, sir. Thank you.
Thank you.
Thank you, sir. You're showing the video, sir?
No, Ashok, there's the next one on
Okay.
midvastus. Yeah.
Yeah, I think over to Kiran. I think Kiran will be showing the lateral parapatellar and the midvastus combined. Yeah.
Thanks, Ashok. So the transition to midvastus for me happened in 2024 when we studied 100 patients with subvastus and compared them with 100 patients with midvastus. And we found that the midvastus was superior to the subvastus. So having done subvastus for almost 16 years, now I changed my practice to mini midvastus, and 80% of my patients go home within 24 hours now. So incision is a midline incision, which is slightly towards the medial side. And you can see that we are exposing the vastus medialis obliquus there. And the dissection is subfacial, as Dr. Gurava Reddy pointed out. The inferior half of the incision is similar to the standard parapatellar, and that is the L capsulotomy of a subvastus approach. But there are 3 different insertions of the VMO. Sometimes it's a type 1, sometimes it is a type 2, and sometimes a type 3, where the insertion goes more below onto the patella. The midvastus approach splits the vastus medialis obliquus, and nowadays the modification is a mini midvastus approach where we just take about 1/4 of the muscle off, and you can see that the angle of cut is about 110 degrees into the muscle, and you have a nice tissue to close it back at the end of the procedure. So some of the challenges with the subvastus approach are that sometimes the skin incision length has to be longer. Sometimes there is ecchymosis and bleeding, which the patients find troublesome because the perforators may be injured or something like that. However, it is not serious. Patients have good extensor function, but we found that this particular approach allows better exposure of the anterior femur through a smaller incision, and the postoperative recovery is almost identical. Sometimes it is superior. In the 30 patients where we studied subvastus versus mini midvastus on the 2 knees, one side was subvastus, another mini midvastus. About 25 patients preferred the mini midvastus side. 5 patients did not have any preference. So this forced me to change my practice, although I was a very massive advocate of the subvastus approach. I found that the early recovery is far superior with the mini midvastus. Now, a lot of people with kinematic alignment talk about the coronal plane soft tissue, but I think the quadriceps is a more important soft tissue than the medial collateral ligament. I'm sorry about that. So, just a second, I just had some. Right. So at this stage, you can subluxate the patella. You don't evert the patella, but you can take out the patellar osteophytes and use the mobile window technique, as Dr. Nilen was pointing out, in order to expose the different aspects of the knee joint. Most of the times, you don't need to evert the patella, you just subluxate the patella. And sometimes the incision may have to be increased a little bit proximally in order to be able to safely expose the entire knee joint. And you can see that the entire knee joint is properly exposed. You excise a part of the intrapatellar fat pad in order to expose the lateral border of the femoral condyle. And you can do all your soft tissue releases, bone cuts, and implantation in a proper manner. Once that is done, the closure is pretty straightforward. You can see that the flap which we opened up just falls back there, and you can close it pretty well. Sometimes found that if you cut into the vastus medialis, then the muscle sometimes can get damaged. But this approach modification, where we are cutting at an angle of 110 degrees, entering into the quadriceps tendon about few millimeters and then going at a acute angle medially, has allowed us to do the surgery without damaging the vastus medialis at all. And the closure is done nowadays using a Stratafix type of suture, and you can see how the muscle is well preserved there at the end of the surgery. And this in conjunction with the enhanced recovery protocols which we are following with periarticular infiltration and the use of intra-articular epidural with local anesthesia has allowed us to discharge about 80% of our patients within 24 hours. So 20% still stay back for other reasons, but most of them are able to do SLR, walk in a few hours, and are able to independently ambulate similar to a subvastus approach. So a couple of stitches in the vastus medialis, and that is what allows us to completely have a watertight closure in this particular approach. And this is the patient on the day 1 of surgery doing a active SLR and getting almost 90 to 100 degrees of range of motion. Any questions on the Midvastus approach I can take? If there are no questions, then I will show a short video on the lateral parapatellar approach. Ashok?
Kiran, any ecchymosis you find in Midvastus?
No ecchymosis in Midvastus at all. So we used to have a 8 to 10% ecchymosis in Subvastus. And I have also been doing Subvastus since 2005. When I picked it up from Dr. Ashok Raj Gopal, who had learned it probably from Rick Berger. And I have continued to do that till 2023-24. And my friend Neil told me that this probably is better. So I just, laughed it off. But I did a study in my unit where we did 100 cases. And we found that the early recovery was superior with this approach. So I had to eat the humble pie and had no choice but to shift to this particular approach.
Thanks, Kiran.
Do you use tourniquet?
I use tourniquet, sir. I have tried without the tourniquet and I don't find much of a benefit, although I think there is overwhelming evidence now that without tourniquet is probably a better option. In my unit, I don't do that many bilateral operations and I do mostly unilateral. So if you're doing bilateral, I think you should not use a tourniquet. Unilateral surgery, I don't think it makes that much of a difference.
And if the tourniquet time is shorter, 30 minutes, I don't think doesn't make any difference. Yeah.
No, but I think Dr. Nilen has a point. A lot of studies have come out that the thigh pain because of the tourniquet and then other complications are higher, especially when the tourniquet is being deflated. There is a lot of emboli which can go in and all that. And if some unit is doing simultaneous bilateral operations routinely, I think it's a good idea not to use the tourniquet.
Okay. Yeah. Thanks, Kiran. Yeah.
Right. So so for non-correctable valgus knees, we have been using the lateral parapatellar approach with coronal plane Z-plasty of the patellar retinaculum. We know that the lateral structures are shortened here, and unlike the varus knee, it's not a single structure. And you also have the lateral collateral ligament, which is attached to the fibular head. So you cannot release the tissue and then get complete correction. So non-correctable valgus knees, it is important to address the patellar maltracking as well as the shortened lateral tissues using this coronal plane Z-plasty, you can see that the proximal and distal incisions are similar to that of parapatellar approaches. You can go lateral subvastus there, or you can do a rectus snip or something like that. But this is a tissue which is about 3 to 5 centimeters in the peripatellar area, which is lengthened. So you cut it in a U-shaped manner, and you use a number 15 blade to do a coronal plane Z-plasty of this particular tissue. And most of the contracture in the valgus knee is related to the ITB, and these tissues contribute to the patellar maltracking as well. So the moment you are lengthening this tissue into two halves in the coronal plane, so it's called as coronal plane Z-plasty of the patellar retinaculum.
Kiran, the video is not seen, Kiran. Yeah, video or presentation is not seen.
Video is not seen?
Yeah.
No, but
We are not playing.
It's not playing?
Yeah, not playing.
Just a second, 1 second. In my laptop, it is playing. Okay.
You know, share it, I think. Put it in the PowerPoint and then.
No?
Yeah, yes, sir. Yeah, yes,
Yeah,
Kiran.
now, yeah.
Yeah, perfect.
Sorry. Is it playing now?
Yeah, it's
Yes,
playing.
yes.
Yeah. Sorry about that. So I was talking about the coronal plane Z-plasty of the peripatellar tissues to lengthen the lateral compartment. So that's the U shape being marked there. The proximal and distal extents are similar to that of a parapatellar approach, any parapatellar approach. The proximal extent, you can do a lateral subvastus if you are very keen on that. Distal part, the difference here is we don't excise the intrapatellar fat pad. It is preserved. And you make a sort of a coronal U there and then lengthen it in the coronal plane. So the Z-plasty is in the coronal plane. So I'll just show you that. So I'm raising that tongue-shaped flap from the peripatellar tissue, which is between 3 to 5 centimeters in length. And I'm using a number 15 blade to divide it into two halves. One, the anterior half, another the posterior half of the lateral tissue. So these tissues can be sutured back once the surgery is done, because the valgus deformity gets corrected. This tissue usually cannot be closed in the classical Keblish approach. So this modification allows us to close the tissues in a very safe manner, and there is no incidence of wound healing problems. And since the pathology is more lateral, the access to the posterolateral tissues, everything is much easier, and the release is much more calibrated. Also, since we are raising the flap from the tibia, we are able to release the ITB completely. And as we know, most of the problems in the valgus knee are related to the contracture around the distal lateral femur and the ITB contractures. Of course, sometimes you can have the combined lateral collateral ligament and popliteus contracture as well, which can be addressed through a lateral epicondylar slide, again directly through this particular approach. If you do a inverted cruciform release or soft tissue releases, then a lot of the times you will have to increase the constraint here, because you have a partially competent medial side along with some sort of a lateral side which you are making incompetent by releasing all the soft tissues. Since it is not a single soft tissue like a varus knee, we cannot release the entire sleeve and then repair it back and hope that it will work. So here I am clearing up the lateral gutter, and you can see that the ITB is nicely accessed from the tibia, and you can release the entire ITB directly from the tibial insertion onto the Gerdy's tubercle. And this allows internal rotation of the tibia and access to the posterolateral corner and the posterolateral osteophytes in a very nice manner, so that the severe deformity automatically corrects after the exposure itself. And a lot of the times you can end up doing a less constrained option like a cruciate retaining knee in this situation. So you can see that 25 degrees of valgus deformity has completely corrected. And at the end of the surgery, you can put this is a CR insert which we have put in, and that's the tissue which is being closed back. The intrapatellar fat pad is used for inferior closure, and the Z lengthening is used to close the peripatellar tissues. So you have adequate soft tissue cover of the implant. That's how it looks at the end of the closure. And that's the range of motion and stability after the surgery. Thank you.
Kiran.
Yeah, thanks, Kiran. Any questions to Kiran? Yeah. Anil, sir, we need a... Yeah. Let's go to the hip session now. So, I invite Dr. Kartik Patel to take anterior hip, starting the anterior hip, approach the anterior hip. So, welcome, Kartik.
Yeah, so good evening all, and thank you, Ishk, for inviting me for the talk on the anterior approach. And so this is a video presentation. So I'm demonstrating the direct anterior approach with the routine table, not any specialized table. So yeah, video is visible?
Yes, video is visible, yeah.
Okay. So patient should be on the edge of the table, and the break is at the level of the GT so that we can get the hyperextension. Pre-operatively, we measure the limb length so that we can correct the LLD as much as possible. And after the, so first for the hip exposure, for the femoral elevation, we do the Trendelenburg test and the extension of the at the level of the break so that we can have the femoral elevation. CM comes from the opposite side and we correct the all parallax effect. For the direct anterior approach, we paint both limbs together so that the bilateral DA-THR is very easy with the direct anterior approach. First, we mark the ASIS and incision start 2 finger below and 2 finger lateral from the ASIS towards the fibula head. We identify the TFL belly with the internal rotation that makes the TFL proud. Incision in the line of the skin incision, and then first comes the proper interval, that's the TFL fascia. TFL fascia is bluish in color, while the fascia or the sartor is in whitish in color. And the TFL fascia has a multiple punctate vessel, which you can see. Also, peculiarity is that TFL fascia will give you a twitch, while the sartorius fascia will not give you a twitch. And this is a constant finding. And we can identify the TFL fascia and enter. We cut the TFL fascia in the line of the skin incision, grab the superior lip, and we can see the direction of the TFL would be downward and outward. Rather, direction of the sartorius would be only downward. Once we detect the TFL posteriorly, then we come over the rectus fascia, and you can see the white, red, yellow junction. We open the rectus fascia at the level of the junction of the red and yellow and detect the rectus anteriorly. This movement goes superior neck outside the capsule, and then main vascular structure comes is the LCFA. This is the potential source of the bleeding, which we need to be taken care properly. So we skeletonize the vessel and take care proper control of this LCFA, because that can cause the hematoma in post-operative period. That bulging muscle is the vastus from the vastus fascia. So once we taken care LCFA, then another spike goes inferior neck outside the capsule. So we have 2 spikes, one superior neck, one inferior neck, both are right now outside the capsule. Then comes the elevation of the iliocapsularis, that's a vestigial muscle. We elevate in the direction of the opposite kidney, and we find some kind of the dip in the pelvis. And the anterior column spike goes between the 0 to 13 degree as shown in the PIP. So in this drawing, I'm showing, so we do the capsulotomy in the I shape. There is the anterior iliac spine, and this spike goes medial to the anterior iliac spine in the direction of the opposite kidney. In initial cases, you can do the complete capsulectomy. Literature-wise, there is no difference. But right now, I start preserving the capsule, and I do the I shape or S shape. So vertical limb goes between 2 retractor. And once I put the vertical cut, then I take both retractor inside and stretch the capsule. Release the capsule completely from the intertrochanteric line on the femur side. And we can see the intertrochanteric tubercle. That's the constant finding too. After we release the capsule completely from the femur, then we go on the acetabulum side. And the release of the capsule from the acetabulum side from the supralateral region makes lots of difference in the femoral elevation, because that is the continuation of the superior capsule which attach over the acetabulum. which allows the lateralization of the femur while preparing the femur. So you can see I'm releasing the capsule from the supralateral part of the acetabulum completely. So you can see this is a superior capsule which is attaching over the supralateral region of the acetabulum. So this will help while I'm doing the femoral preparation. After this part of the release, we go on the medial side, but I would be careful because I don't want to damage the psoas muscle. So I do the undercutting and be careful in the cutting the capsule. So taking the neck cut, either you can take the single neck cut or double neck cut, depending on the pathology in our training. When you take the neck cut, make sure you take in the internal rotation and you protect the TFL belly because the side blade will cut the TFL. So we take the neck cut, another neck cut. So in this case, I take the double neck cut. So initial cases is advisable to take the double neck cut, so that will decompress the whole hip and you can remove the femoral head easily. So, and the neck cut depends upon your pre-op planning and the templating and whether you are dealing with the coxa vara or coxa valga. And removal, you should remove in the direction of the TFL, not perpendicular TFL, levering over the neck. So once we remove the femoral head, then release comes the pubofemoral ligament. That's the structure attached over the calcar, over the medial aspect of the calcar, above the LT. So you can see in the PIP. So release of the pubofemoral ligament allows the proper external rotation of the femur, so that your calcar should start pointing toward the ceiling. This release is also important in the femoral elevation and the acetabulum preparation because that allows the femur mobilization so that you can push your femur more posterior, and that will not push your femur acetabulum femur more anteversion. So we should release, we must release till we see the LT. So after the release of the pubofemoral, this spike goes over the posterior column. This goes just below the tal, middle to the teardrop, and this is over the anterior column. So three spikes is okay for the acetabulum preparation. And you can see in the PIP that the tal spike goes just middle to the teardrop. After acetabulum exposure, we remove the labrum and ligamentum teres. And we can see that wonderful, you can have the wonderful visualizer of the acetabulum in the direct anterior approach. We can see the tal, we can see the cotadal fossa, and then start preparing the acetabulum. Tal here is the more anteroinferior structure rather than the inferior structure from the posterior, unlikely compared to the posterior approach. You can prepare the acetabulum under the fluoroscopy in initial cases, and the version inclination you can check under the fluoroscopy guidance. So once you put your component, so you can see that I touched the collar line, I am at the level of the teardrop, my version and inclination looks okay. So once we prepare, then comes the femoral elevation. The superior structure, superior capsule is paramount release because until unless you release the superior capsule, your GT will not come up. If your GT will not come up, your femur will not get elevated. So superior release is most important. There are so many variations of the superior capsule release. I usually put the two incisions like in this video. First incision goes just anterior to the posterior cortical line, and we never cross posterior to posterior cortical line because we don't want to release the obturator externus. So once you cut the superior capsule, you can see the fat pad sign. So you can see in the video that fat pad. After the superior capsule release, if you find difficulty in the elevation, then you can go the release of the conjoint tendon, which is attached over the anterior to the piriformis. Piriformis fossa is the misnomer because obturator externus is attached in the piriformis fossa, while the piriformis is over the tip of the trochanter. So if you want to release the piriformis, go to the tip of the trochanter and release the piriformis. So I am demonstrating the release of the conjoint tendon for the better elevation so that I can take the entry near the footprint of the obturator externus near the piriformis fossa. So that and this is a lateral RAS. So once you put, it will automatically rotate and you clear the lateral shoulder and then start preparing with the broaching. If you are using the collar stem, then you need to use the calcar planer for the better sitting of the collar. So in the direct anterior approach, the hierarchy goes like superior capsule release, then conjoint tendon and the piriformis. We never release the obturator externus from the piriformis fossa. The reduction in the direct anterior approach is very easy with the 2 fingers only. My assistant gives the traction and I push with 2 fingers. We measure the limb length. We check the stability in all range. Major cause of the dislocation is the impingement, and you make sure that there is no impingement between the neck and the liner. And dislocation is the tricky because if you don't put hook, your head can dislodge from the neck and goes in the pelvis. I check the size of the stem under the fluoroscopy and then final implantation of the stem with the proper sitting of the collar on the calcar. Neck, head, original, and then reduction. If you have preserved the capsule, you can take the suture. I believe that capsule preservation gives some kind of the stability, and it is a very thick structure. So after a few cases, like 50 or 100 cases, you can start preserving the capsule and the repairing bed. Thank you.
Thanks, Kartik. That was an excellent demonstration. So what was the experience, Kartik? How initial learning curve, how many cases you took to do this?
A learning curve would be around 50 to 60 cases. And the major problem lies in the timing. So if you are doing the posterior approach, your timing would be 20 minutes or 30 minutes. Suddenly it goes up to the 2.5 or 3 hours. You have to do DA, but your staff, 40 staff, your anesthetics starts saying, just finish in the posterior approach. Why are you spending so much time? So yeah, so the learning curve would be around 50 to 60 minutes. And once you cross that part, then you start loving the approach.
Okay. So thing is, we are used to the coplanar test, all these things. How do you assess only by CM?
Yeah, so there are few things which is not applicable in the direct anterior approach, unlikely the posterior, like the coplanar test. We cannot check the coplanar test. We cannot have the tibia axis for the femoral stem version. So we follow the posterior cortical line in the femoral stem version and the sub test. So if you see the direct anterior approach, the reduction is very easy. With just 2 fingers, and your hip would be suck a lot compared to the posterior approach. Still, it will not get dislocated because of the soft tissue you preserve. So initially, I used to lengthen the hip because I found that its hip is sucking a lot. My reduction is too easy. But eventually, I learned that if I keep it the loose, it will not get dislocated. So a few things, yeah.
Kartik, one very important, you are a master, how to prevent fractures, in femur, femur is little difficult. So can you give some tips how to avoid femoral stem going into anterior cortex or avoiding fractures?
Yes, sir. So the whole learning of the direct anterior approach lies in the femoral elevation. And for the femoral elevation, we must understand the anatomy well, because traditionally we thought that the piriformis is anterior than superior than the conjoint tendon, but the whole anatomy is very different. So proper femoral elevation is the mandatory, and for the proper femoral elevation, proper releases are the mandatory. Once you have the proper elevation, take entry from the near to the piriformis fossa, near to the obturator externus footprint. If you don't have the proper femoral elevation, like in my initial cases, I had 2 fractures. I need to convert to the posterior approach. Because my entry was more medial and anterior, so my stem was going in the varus and hitting the posterolateral cortex, and that caused the fracture. So proper elevation, proper entry is mandatory. Use the fluoroscopy. It's very easy to use the fluoroscopy in the supine position. So fluoroscopy and just give the time to understand the anatomy, time to execute the surgery, and you start seeing your hip just start subluxating anteriorly, and you start preparing femur then only.
Very
what are
good.
the ideal cases?
Can you tell us?
Yeah. What are the ideal cases for the beginners to start?
Ideal cases would be lean, thin, not so obese, coxa valga, not wide pelvis, because there is a term abotrochanteric space. So if you have good abotrochanteric space, you can get good access. Acetabulum is very easy in the direct anterior approach. The whole crux lies in the femur. So if you don't have the good space above the trochanter, you don't get access to the femoral canal. then you might need to do some kind of the secondary releases and some different maneuver. So if you have the coxa, short neck, stiff hips, wide pelvis, those are difficult cases. So choose the coxa valga, choose lean and thin person, avian, but sometimes it's very difficult to find those cases in initial.
A fracture neck of femur is not recommended in bipolars?
Yeah, fracture neck of femur, if you are doing the total hip replacement, that's okay. But in the bipolar, because two reasons, it's very difficult to reduce the large head to put on the trunnion and reduce it back is very difficult compared to the 32 or 28 head. And those are the osteoporotic patients. So if you don't know the releases, you might crack the femur. Calcar fracture, shaft fracture, sometimes supracondylar fractures too. So avoid the fracture neck femur in initial cases. And if you find good bone stock, nearly younger patient, so you can plan the total hip replacement, dual mobility at least.
Yeah. Thanks, Kartik. So any questions from the panel, you can ask Kartik. Yeah. Bhosale, sir? Yes.
Yeah. What is the leg position? Can you guide us for that?
So leg position.
Femur, yeah.
Yeah. So for the femoral elevation, first goes the capsule release, then you put the spike. Okay. Don't try to do adduction and extension before you have the femoral suppleness. So you can put the hook in the neck and you can find that your femur starts suppling. So that means you have done the proper releases. Then put the spike, then give the adduction, extension around 10-15 degrees, and the flexion of the knee not more than 30 degrees. If you flex knee more than 30 degrees, that will contract your rectus and push your femur downwards. So now the Belgium surgeon like Christophe Cotton never do the hyperextension, and the Frederick Lord do always hyperextension. So we can take the middle path. We do some releases, we do some hyperextension. Overall idea is, if I'm not doing the hyperextension and I'm damaging the TFL, there is no role of doing the direct anterior approach. Ultimately, it is the soft tissue respecting surgery. To prove something and I'm damaging, there is nothing good about it.
Thanks,
so we
Kartik.
can always, yeah.
It's very good demonstration. But
Yes, sir.
Yeah, your
If
opinion.
you are in trouble, can you extend your approach?
Yes, sir. So direct anterior approach is extensile approach. We can extend in the laziest fashion, like lateral femoral approach, and we can do the subvastus like what we do in the DHS plating, and the whole femur we can expose. Proximally, we can expose to the ilium, to the TFL snip, and like what iliofemoral, modified iliofemoral approach, we have the both access to the inner table of the ilium and outer table of the ilium. So it's extensile approach. If you have done the bikini, then it will be difficult because bikini cannot be extensile approach. So I always tell my fellows, now I do a lot bikini incisions, but I always tell my fellows, don't do bikini in initial 200 cases, because if some trouble occurs, if fracture occurs, you can't do the extension. You need to put the separate lateral incision, and that you find difficulty or maybe ugly.
Yeah. Thanks, Kartik. Yeah.
What is roughly the lateral cutaneous problem?
So in my case series, around 50% of the patients have feeling the numbness, which eventually over the 4 to 6 months taken care of, because there are 3 variations of the lateral cutaneous nerve of thigh: sartorius, posterior, and the fan shape. And the distribution is equal, 33%. So we never know which kind of the patient is that. So in my series, 50% of patients have the numbness or some kind of the neurological pain, which eventually go over the 4 to 6 months.
4 to 6 months?
Yeah. So numbness, the part of the numbness. So numbness of the later part of the aspect of the thigh. But it is not troubling to any patient. So it's not classical lateral cutaneous nerve thigh of injury, but some kind of the branch, which may be fan shape or maybe posterior type of the variety.
Thank you.
Thanks, Kartik. It's over to Anil.
Thank you.
Yeah.
Thank you, Ashok, and thank you, Ishq. I think I'll move over to the anterolateral approach. 1 minute. Is my screen visible now?
Yes, seen, Anil, yes.
Okay, good, great. Thank you, ISHK, and thank you, ISHK team, for having me here. I think after that wonderful presentation by regarding the anterior approach, we'll move on to the anterolateral approach, which has been our workhorse in all primary hips. Actually, we started with the anterolateral approach. In all of you know the plane. We started the anterolateral approach in the supine position. Now we moved on to the lateral position because it's easily versatile. And the only modification that we've done is basically the mapping modification. We've used that to basically preserve the posterior two-thirds of the gluteus medius, and that has been a very, very useful step that we've adopted, and that has been very good in preservation of the abductor function as well as the capsule and the repair per se instead. So now if you look at the routine workup as we do in our unit, we definitely template, and once we template, we get an idea of the acetabulum and femoral components, and the next thing is we proceed to positioning on the table with good lateral supports. The only difference from the posterior approach is we make this incision towards the anterior aspect of the trochanter. Once we do that, we have made this incision for demonstration purposes. Also, the distal part of the incision is the best point to identify the TFL. Once that is done, the leg is held in little abduction so that the TFL can be easily delineated. And then what we can do is we can definitely elevate the bursa which is there. We can either cut it for repair subsequently, or we can get the whole view of the gluteus which is in position with the self-retaining retractors in place. We use these retractors, and once we do that, the next step is very important. We don't do the classical hard hinge where we take off the entire abductor. It is the anterior 1/3 or roughly the anterior half that is differentiated. And the very, very important step for suturing back is that the elevation from the trochanter is done at the musculo-tendinous junction. This plays a very, very important role because reattachment is very, very crucial, and that is what we do ensure in every case. The next step is cutting the gluteus minimus and the capsule, and if you look at it, it's in a much more vertical direction. It's towards the 12 o'clock position. That, in fact, facilitates your entry to the femur, preparation of the femur, and also the access to the entire acetabulum. So if you look at, in a nutshell, your gluteus medius anterior 1/3 to anterior 1/2 is preserved, and your gluteus minimus and capsule is in a more vertical fashion to enable exposure and also to get your access to the acetabulum and the femur without damaging the rest of the abductor. So if you look here, the rest of the procedure where we actually elevate the anterior capsule and actually get access to an easier dislocation is by releasing that entire anterior capsule. Again, I think it's slightly similar to what Kartik showed. We work on the inferior aspect of the neck. You realize that you release all the attachments and the capsular attachments inferiorly, keeping in view where the lesser trochanter is, because all these muscles that are contracted or all the tissues that are contracted have to be released in sequence, because we do not want what we call a traumatic dislocation, because we try to dislocate it anteriorly. So the capsule both anteriorly and inferiorly is released, and the next step is where we are ready to dislocate the actual head of the femur. So this is very, very well done and can be done without much trauma if the release is done as described here, and it becomes much easier to actually dislocate it. And once you bring it out anteriorly, the pouch that we have in our drape is very, very safe so that you can position the leg there, and then we can proceed on to doing an osteotomy of the neck. So in this particular position, it's easy to identify the lesser trochanter, get the rest of the neck, and then bring it back to the normal position where we do the neck osteotomy. So the neck osteotomy is done as planned. We have the template that is done. So we know that we have to make the osteotomy there where the neck cut or where the template dictates us. And then we do all the releases basically from the inferior capsule, define the tal, protect the iliopsoas, and continue to define the rest of the acetabulum. Once we do that, we position the homens in such a way that you get an excellent 360 view of the acetabulum. And this is what is very, very important before we start reaming or even start preparation of the acetabulum. Defining the margins. Now remember that it's distorted. Most of the times there are osteophytes. So it's very good and very prudent to spend 5 extra minutes here to basically remove the capsular tissue and the labral tissue and get your labral retractors in place. And this is a very, very useful set of retractors we have. The posterior inferior capsular retractors, where we position it, and thereby the posterior and the inferior capsule is moved out of the way and the entire acetabulum comes into view. and then you have the anterior retractor that's placed, which gives you an absolute 360 view of the acetabulum. Once that is done, the next step is basically you have this position, you have that position and you're ready to start your reaming. And that is what is very, very important, because then you can determine your version, your inclination. The only point that we got to remember when we ream in the anterolateral approach is our tendency to excessively antivert the cup. So that is what should be avoided when we position our positioners and you take your final component position into consideration. Now, turning to the femur preparation, it is actually slightly different because the femur is delivered anteriorly. It is slightly different from the posterior approach because your version is actually visible to you, and that is dictated by a line drawn across the cut section of the neck. And once we do that, it is very, very easy to change your orientation, or very, very easy for us because we are accustomed to this approach. Once we do that, we define or release part of the posterior capsule there in order to make this delivery of this femur easier into the wound. And that is where the posterior neck capsule is cut. And that is where we put a blunt homens underneath so that we can actually define the posterior margin, and then we can have the delivery into the wound. So that way you can have that done. And once this is done, your posterior margin and your anterior margin lateral, you get your orientation where your lateral is, and then you start in the lateralmost position to prevent varicization of the component. And once we do that, we follow the steps where we get a direct access into the canal, and delivery of the proximal femur into the wound is done, facilitated by that small blunt homens. And then the process to prepare is very, very simple, because once we get the canal finder, the next situation is the broach, and that can be done sequentially to prepare the femur. And then this is the only difference where we see if there is no significant distortion of the anatomy, you align yourself to the margins of the neck cut, and that itself will get your orientation and version correct as far as the femoral component concerned. Ascertain the stability, and then you're ready for your trial reduction, because that can also change after your trial reduction, but you want to ascertain, make sure the femur is moving as a unit, and then you're ready to do your trial reduction. Again, you can do the combined, I think Ashok was also talking about that, the combined anti-version. You can retract the posterior part and look at it, but in the anterolateral approach, it's very easy to look for your length, for range of movement, for stability. It is very, very easy to assess, and because the posterior capsule is held and kept intact, the whole situation for assessing stability is much better. You can check the entire range of movement, and then your final components are in place, and then you are ready for your closure. So that is your final look, and that is your final stability with an anterolateral exposure where you have left the posterior part intact. Now the attention should be paid to closure. If the musculotendinous junction is respected and it is cut exactly there, closure, it is usually very, very simple to do, because you just take sutures. There's no need for anchors, there's no need for bony sutures. We are able to close it in sequence with a very, very good capsule, followed by medial gluteus medius closure, and then followed by your. So the essential thing is the posterior part of the gluteus is intact, and you have maintained the abductor. The fear of the classic hard hinge is gone, and this is a very, very useful approach in all primary hips, TFL, subacute and skin, and thereby you can get your closure done. And the exposure is very, very crucial in preserving that medius. Exposure of the medius is critical, and that can be done only by moving the incision a little anterior. If you place your incision posterior, you're going to struggle. So that should be avoided, especially in heavier individuals. And that has been our workhorse in our unit for all the primary THRs, except those needing posterior reconstruction. So that, in a nutshell, is what you do. Cut the capsule and dislocate it, followed by your neck cut, 360 margins. And this is what we see. We have no problems in lurch, no problems in function, no problems in functional outcome. And we can reestablish all the parameters without a problem. This is, in fact, people who have come at 9, 10 years follow-up. None of our patients have a lip. And in fact, we have gone ahead and studying these patients with an EMG as well as gait analysis. We have definitely done bilaterals in the same sitting, definitely done unilaterals, complex hips, and this is what we have done. Even literature says there are similar gait patterns, and if you look at the risks that have been described, we have not had significant risks because we respect that zone, and complications as dislocation are definitely much better, on par with any standard approach. And we have had our own studies, especially in our volume of fused hips, that we've had this modified lateral approach that is very, very useful in ANGSPOD. And also recently we have published regarding restoration of the offset and restoration of the biomechanics in the anterolateral approach as well. So in a nutshell, lateral approach is very useful. Modification with our hands has no abductor issues. Orientation is very easy. Avoid excessive anteversion. Acetabulum and femur positioning can be done with care. And obviously, posterior wall column reconstruction, femoral shortening, we always resort to the posterior approach. Thanks, Ashok, and thanks, Ish. I'm happy to take any questions.
Yeah, thanks, Anil. That was a very nicely demonstrated surgery. And that's the workhorse of CMC.
Workhorse, I think if you have a show of hands, Ashok, I'm sure a lot of people will do the anterolateral.
Yeah.
I'm no offense to Kartik, but just to say, I know a lot of people do the anterolateral.
So, yeah, I think any questions to Anil? Please, you can.
Anil, there are 2-3 small modifications.
Yes.
We also do quite a bit of a number of anterolateral approach. Only we do posterior for revision. Anything difficult situation we are likely to, like post osteotomy, or we have to reconstruct something. Then, but a small thing is that before I cut this vastus and the anterior 1/3, I take a straight suture. It helps me. It helps me for the closure, and at the time of reduction, I don't want to struggle. So the whole capsule goes in the front with just 2 sutures. And you don't just otherwise the capsule comes in the way at the time of reduction.
Very, very true. So very, very true. We keep it out of the way. What we do is we tuck it under the self-retaining clamp so that doesn't come in the way.
That is another thing which we do it. And we, as you probably the time was not that enough. The TAL, because anteversion becomes too much for this approach. So we just look at we mark the TAL. And we do one line just on the superiorly parallel to, and our reaming is exactly 90 degrees to that line.
Yes, sir.
So that gives a fair degree of thing.
Yes.
And we were unable to actually, in this combined anteversion, we are unable to, it is a reverse way. It is
but if you retract
rotation, we have to do external rotation.
Correct.
So we were not happy with doing the
but we can check our stability as demonstrated, and it will give you all the information that can also be done with the combined anteversion.
And I think there is another important thing which probably there are no precaution. So we don't have a pillow. We don't anything. They just straight away next morning they just walk.
Nothing. They're happy. Actually, we have increasingly seen the next day they walk without pain, no gait, limp, nothing, and even follow up, they're very happy.
Pain will be there, but at least they are much more, mobile.
With our current pain management protocol, they're very happy the next day itself, sir.
And we do infiltration actually before I close.
Yes,
we do that. Capsule and everything, or Shelby cocktail.
Yes.
So we do that.
Yes, sir. So we do our canal block with our infiltration, as well as now the anesthetic is giving us the iliofacial block also. So I mean, in the sense we have different parameters, so they're very comfortable.
Thanks, Anil. Thanks for giving insights over the lateral.
Again, thank you.
Yeah, it's over to Kalai. So this is our unit's workhorse of posterior approach. Yeah, Kalai. Dr. Kalai?
Can you hear me?
Yeah, Kalai. Yes, Kalai.
Share.
Share screen.
Entire screen share. What happened? Sorry, not able to share.
Minimize. Okay. Yeah, now we can share. Click it on.
Okay, got it.
Yeah, got it. No. Now that you just expand it. Yeah, correct.
Sorry for the glitch.
Yes.
Can you?
Yeah, we can see Kalai. Yes, yeah.
Okay. Sorry. So it's been a nice presentation following Dr. Kartik Patel and Dr. Anil Omen, sir. And it's almost like all the basic principle has been explained. Here, only the interval is going to vary. The posterior approach is the gold standard approach because we will be able to do as of the primary, complex primary, and all sorts of revision. And that is the only approach where everyone is able to give a 100% result. And coming to the theoretical part, the posterior hip approach is the more southern Morey approach, and the Kocher-Langenbach approach, and the Gibson approach. And the advantages, as you know, it gives an excellent visibility of the hip joint. It's a surgeon friendly, helps in the position of the implant very correctly. Muscle splitting approach, and it avoids cutting, and it extends from the complex primary to revision. Disadvantage, yes, a bit of a portion of the dislocation, but when compared to the whole number of series, it is quite, the number will be less. So this is a tabular column where you see a southern approach, Kocher-Langenbach, and a Gibson approach. And the muscle interval, you can see spreading the gluteus maximus and detaching the piriformis and the external rotators in the southern Morey. Coming to the Kocher-Langenbach, it is the interval between the gluteus medius and the piriformis, and Gibson's is between the gluteus maximus and tensor fascial area. Sciatic nerve is to be taken care during all these procedures. And beyond this muscle splitting, in basis of the capsule cutting, most of the capsule is in a shape of T-shaped cutting, but we do a special approach called the neck capsule pressing approach, where you cut the capsule into two halves and close back the capsule, which plays an important role when you play and do a resurfacing, because the vascularity is like preserved. And second, whenever the size of the cup goes more than beyond 154, the intracapsular dislocation chances much more less. And when the capsule to capsule is anatomically close, the patient has a very good internal external rotation and internal rotation, and they are back on their feet on the day one. And this is the approach which we generally see. So this is, can you hear me?
We can see. We can hear and see.
Yeah, so this is the basic posterior approach. Here, just you can see we have just divided into three portions. One is the gluteus maximus attachment area, and second is the greater trochanteric area. Third is above the greater trochanteric area, 1, 2, 3. And generally, we used to release the Gmax depending upon the severity of the case, as like primary or complex primary or division. So like here, the first portion, we release the gluteus maximus insertion, so that the rotation is like internal rotation and external rotation is quite easy when you do a complex hip. Second is, you can see we just preserve the gluteus minimus and maximus, and we just go above the capsule, and you will be able to see the entire capsule from 12 o'clock position, 3 o'clock position, and even the anterior portion. And the greater trochanteric portion, the quadratus femoris is released in a series, and we can preserve. So the incision is quite considerable, and the patient are able to walk on the day one. And you can see that they will be like 100%. There is no lurch or anything what we generally care of. So posterior approach is not an extensile approach. It is a minimal invasive approach. We do totally pre-placement as well as bipolar with a minimally like small approaches. There are like Channa approaches which are explained with the special retractors and reamers. Whenever there is some complication on table, you can immediately expand the incision, and you can do the needful. You can have a very good peaceful sleep. And this patient particularly came from Raipur. He already underwent failed two-stage revision. So the first stage, I removed all the spaces which they kept, and kept a new poly and oxygen head and a cement rod, and the patient was made to mobile, and his general condition improved, albumin globulin improved, and the diabetes mellitus came in control, and everything went fine. We had the option of total femur as well as this, and this is a present X-ray, and the patient has been totally walking good. And the post-osteobular fixation or post-osteobular internal fixation cases are quite high, and posterior approach is a very good approach where you have the ability to assess all the implants, and when needed, pull out the implants and put the implants in the whenever record position. And this is whenever you see like here you see a protrusion of bipolar which goes in. Here we did a removal of the implant as a stage 1, and in the stage 2 I just use the long dual mobility with the jumbo cup concept and as well as a distal fitting stem. And here the posterior approach gives a very good visualization of the cup as well as the femur part extending from the greater trochanter to the condyle. And we have a 10,000 series where the dislocation it is much more quiet, and we have just addressed all these issues in our paper and as balancing totally arthroplasty. And it's all depends upon the technique what we use and the implant what we use and the positioning. As you know, the posterior approach gives a very good idea about the combined combined version on table, and also the coaxial stitch technique which we have explained. It is very cost effective, and you are able to restore the limb length without any discrepancy in almost 9 out of 10 patients, except for the complex and the neck of femur patients. And I have my posterior approach video in the YouTube, which will clearly explain like how we go release the piriformis, preserve the gluteus minimus and medius just above the capsule, and you cut the entire capsule along the C shape and close back into the normal shape. Thanks everyone.
Yeah, thanks Kalai for this presentation of posterior approach. Any questions, please? Yeah, anybody? Pachuri says that, yeah. Let's go to the secretary.
Ashok.
Yes, sir.
As a hip surgeon,
Yes,
one
sir.
should not say that this is the only approach.
Yes,
So
sir.
he must learn at least 2 to 3 approach. It
Yes,
is
sir.
all, yeah, I think it's very important that everybody also should know posterior approach, because it is a very extensive approach you can do for revisions and all other complex cases. There's no question about it.
Yes, sir. This is like a medial parapatellar approach for knee. It's a posterior approach is for the hip. It's a basic approach. It has to be learned by everybody.
Yeah.
Yes.
Yeah.
So Dhanasekara. So go to the secretary. Dhanasekara, you can join.
Yeah.
Dhanasekara is back.
Give me a second. I just. You're able to see my slides?
Yes, Dhanasekara. Yes, you can see us.
Okay. Good evening, everybody. I thank ISHK for the opportunity. Thank our President Pradeep Bhosale, our Secretary General Dr. Pachore, the Trustee, Managing Trustee, and all the board members. And we're going to talk about extended trochanteric osteotomy and integration technique. This is the main workhorse for all the revisions. So what is extended trochanteric osteotomy? It is a controlled surgical osteotomy of the greater trochanter and the lateral femoral cortex, extending distally along the femoral shaft. We can see the diagram. It is just lateral to the linea aspera and the posterior aspect, involving the lateral 1/3 of the femoral cortex and the anterior 1/3 of the cortex. So we do multiple drill holes, and we calculate the length of the stem to be removed, and just proximal to the tip of the stem, we do multiple drill holes, and you raise a flap. It is a osteomuscular flap with intact attachment of all the gluteus and vastus. And once you have done the revision, we close the flap with a tension band wiring. Planning is very important. This is an example of a patient with extensive osteolysis of the femur. Any attempt to dislocate or try to remove the process will lead to multiple fractures. So we need to calculate the length of the osteotomy from the tip of the trochanter to the just proximal to the tip of the stem. We do the osteotomy. We make sure distally there is 4 centimeter of diaphysis available for distal stem fixation. From the bed of the stem, at least 7 centimeter distal prosthetic bed should be available. So you should not extend the osteotomy distally so that you don't have isthmus to get your distal fixation. So try to limit it to the upper part of the femur. So this is a video, a demonstration, cadaver demonstration. This is a posterior approach. That's a stem inside. This is a revision stem, so there's a longer incision. So with the scale, we measure the length of the osteotomy. The facial lata is dissected, and we need to expose the lateral third of the femur So opening up the vastus lateralis, we put a Omen there, and we preserve the gluteus maximus attachment to the femur. And once you expose the lateral part of the femur, you mark the osteotomy again from the tip of the trochanter, and we make multiple drill holes. Once you connect the drill holes, the osteotomy is complete, so that to avoid a accidental fracture.
प्लेट पाई है ठीक है
You can mark it with just marker pen or use this KOI technique. So this is a posterior cortex which has been drilled. Now we going to the lateral cortex. We mark multiple drill holes, and proximally we try to preserve the attachment of the gluteus medius and the conjoint tendon. You don't release it. We connect the holes with the saw. We use a small saw, the distal part of the osteotomy, and then we connect it so that we take the entire trochanter, greater trochanter, with the soft tissue attachment as a single layer. So we need to stay lateral to the prosthesis. The direction of osteotomy is very important. You should not go and hit the prosthesis. You try to go lateral to the prosthesis. If there's a cemented prosthesis, we just go through the cement mantle. It's easy to do the osteotomy. So if the uncemented prosthesis, then you need to work around the prosthesis, go to the interface and with a flexible saw and work around the prosthesis. So this is the most weak area, just below the greater trochanter, the DHS entry point area. This is a very thin bone there. There is a potential for fracture there. So it will be very gentle in that area. You can see the osteotomy goes through the lateral to the stem. On the lateral side, it is just hitting the prosthesis. And we use multiple osteotomes to elevate the osteotomy as a single layer. So superiorly, we connect the osteotomy with the osteotome through the cancellous bone. Once you do that, the entire flap opens up. Once you open up, we have the medullary canal access. We can gently remove the stem and go for the revision fixation. And finally, we close the osteotomy with multiple wires. So what are the indications for extended trochanteric osteotomy? One is removal of a well-fixed stem. Second is removal of a broken stem. Infection control in a chronic PJI, where you need to remove the entire cement mantle or entire prosthetic bed and cure it thoroughly, is the best option. Proximal femoral bone loss in approach type 3 and 4 need to gain access to the distal part of the canal. So we need to open up the proximal femur to get a distal fixation, and complex revision requiring canal access. So this is an example of a aseptic loosening of the cup with a well-fixed stem. This is a zymolar stem. It's a rectangular stem occupying most of the femoral canal. Only way it can be removed in a well-fixed stem is doing an extended trochanteric osteotomy. So this is how it appears in trop. The entire femur stem is exposed, and distal fixation is achieved with a long stem, and the osteotomy is closed over the proximal femur. Another example, uncemented stem loosening with the proximal migration. It is perforating to the lateral cortex. Very thin piece of bone is there. So what is the problem here? We will lose the connectivity of the greater tuberosity to the distal shaft of the femur. To prevent it, we do a calculated calful extended trochanteric osteotomy, keep the lateral cortex intact, and then get a distal fixation. And because of the subsidence, we can see the distal isthmus available is only 2.68 centimeters, and distal fixation is going to be a problem. So we need to put a prophylactic cable so that distal fracture does not propagate. So this was done with the Wagner long stem. You can see the distal fixation has been achieved and the proximal osteotomy has been closed. There is a void in the mid-third of the femur. At follow-up, we can see the union of the extensor trochanteric osteotomy and reformation of the bone of the lateral cortex is quite strong now. Now it is 4 years follow-up and patient is doing well. So another example, broken femoral stem with a well-fixed cemented stem, extended trochanteric osteotomy and distal fixation and the closure of the osteotomy. Another example, aseptic loosening, where the proximal femur is quite osteoporotic and there is a high risk of fracture. So we don't dislocate the hip, we expose and do the extended trochanteric osteotomy. We do in situ removal of the prosthesis and we put a distal prophylactic cable distal to the osteotomy and close the osteotomy proximally. And this is how it looks in the X-ray. Another example, anterolateral and bowing of the femur with gross remodeling in an osteoporotic individual. So if you're using a distal loading stem, it's going to perforate to the lateral cortex. Here, the only way to correct the bowing and get a distal fixation is the extended trochanteric osteotomy. So you can see the medullary canal, it is bowed and the straight stem is going to hit the lateral cortex and the anterior cortex. So we do a corrective osteotomy and then close it over the stem. Is a follow-up of 4 years and fixation is quite stable and there is no subsidence and the ETO is healed well. Another example, infected revision, long stem. Here again we opened and then closed the osteotomy, allowed it to heal and went for the subsequent revision. The long stem bipolar is again a problem, especially infection with distal semen mantle. The ETO is quite long. So here we don't go distal to the stem. We try to be a little bit short and try to work around the stem distally so that we have a distal fixation. So the stem has been removed, spacer has been applied. And you can see we limited the osteotomy just proximal to the tip of the stem so that while reconstructing the femur, we have a distal fixation here. This is a different case where we are doing a different type of osteotomy. I generally approach my hip through anterolateral approach. This is a DOR type A failure because of a proximal bowing of the femur. So I prepared the femoral medullary canal with this flexible solution reamer. When I introduce the actual stem, because of the bowing, it is perforating the lateral cortex. So it's a long stem with a distal perforation. So this is how it appears. So for this, we do an alternative technique called Wagner's transfemoral osteotomy. It's an anteriorly based flap and it involves almost half of the shaft of the proximal femur. It is more than 15 centimeters and gives good exposure and allows correction of the proximal femoral deformities. You can see the comparison, transfemoral versus ETO. Transfemoral is anteriorly based osteomuscular flap. It's almost involving 1/2 of the proximal femur and is longer. So I did a transfemoral approach here, opened up the proximal femur and used a long stem and achieved a distal fixation. And because of the bowing, the flap was not, the osteotomy was not closing over the stem. So I had to use a high-speed burr, reshape the bone so that it sits on the femur and I was able to close it over the proximal femur. So this is the final picture. You can see the long osteotomy and correction of the bowing and distal fixation achieved. The post-operative protocol, first 6 weeks, you allow only toe-touch weight-bearing walking. We don't allow active SLR or active abduction to avoid the non-union of the ETO. If you have a stable fixation on table, it's fine. Otherwise, in osteoporotic patients, better to delay weight-bearing for 6 weeks. And we continuously follow up with the Lowenstein lateral view and the femur for the subsidence. The key advantages of ETO include controlled exposure of the femoral canal, reduced risk of iatrogenic fractures, ability to protect soft tissue attachments, and a very high union rate, more than 95% in literature. Thank you very much.
Thanks, Dhanasekara. It was a very nice discussion, presentation of the video. The cadaver was good.
Yeah, the AO video. So being an AO chair is an advantage.
So, any questions to Dhanasekara? Yeah.
Dhanna,
Yes, sir.
2-3 issues with this osteotomy. You are not keeping the vascularity intact. What we do
Yes, sir.
is a little modification of Wagner. We
Yes.
try to keep vastus completely intact. We don't expose
Okay.
medial to the vastus at all. We will
Okay.
try to do the multiple drill, whatever is showed and distal. We'll try
Yes.
to use the very thin osteotomes and try to
Yes.
sometimes curd osteotome to go on the opposite side. Very
Yes.
rarely I've gone on the medial side and drill it. It is a little
Yeah.
dangerous, but you can do it with your AO guide. AO
Yes.
drill guide. You hammer it inside and try to do the multiple holes so that you don't damage the vascularity. So whole of my
Yes.
flap, muscular flap, is fairly intact. And if you sometimes you have suppose you are got a cement lower down below your 15 centimeter, so you stop the osteotomy there and go
Yes.
2-3 centimeter and make a short window there, and you can take it out.
Yes.
So that is another trick which I learned from Professor Velinagar.
Yes, sir.
So that
I absolutely.
you can use it. And I don't
Yes, sir.
allow them to really weight bear what you say, because you can't rely on this patient to do a partial weight bearing. So I really 6 weeks is out of question as far as I'm concerned for transfemoral. And myself and myself and Dr. Kulkarni has collected the enough data. We will be publishing this long-term results of this transfemoral.
Yes, sir. So this is for the beginners. I just demonstrated how to do it. As we start doing it more, we try to preserve more of the muscle attachment to the femur. I do follow what you advise. I just drill hole through the muscle and using a drill guide so that the soft tissue is not stripped. I absolutely agree with what you said.
Yeah. Thank you, Dhanasekara. I think it's over to Suri, sir. The last presentation is TTO, tibial tubercle osteotomy. Sir can share the screen, sir. I think sir is not seen.
Dr. Kincha sent a message that he is in the Norway.
Yeah, Northern Lights.
Yeah. He is not able to join. He conveyed his excuses.
Yeah. Suri sir is joining.
So Ashok is a good first start. I think the multiple topics, so many speakers, and Thursday evening is good. Usually
Because,
Saturday night, everybody is busy.
No, every Saturday there is some meeting, the other people are traveling. So I thought a weekday, working day should do the meeting. But Thursday, nobody travels. So I think Thursday and 8 to 9:30. And it's because all the FNBs, no? DNBs, we can have a surgical approaches. It's like, yeah.
So it should be available online in our website so that people who have missed it today can go back and see that.
Correct, yeah. I think Suri sir.
And
yeah.
And last year in the ISHK meeting, we had more than 150 new registrations. And they have been quite busy in the ISHK office last few months. They are sending all the certificates one by one. Another thing, our president has been invited to CCOT as a guest speaker. Congratulations to Dr. Pradeep.
Yeah, I think we'll try to coordinate with some other organization. Let's see.
Yes.
Have called for a special president meeting of Asia. So something which we may try to make some attachments.
Yes, sir. Another update is we have a research chair who screened the studies for research grants. And recently, one of the studies have been approved by the president and the trustees. So invite all the interested candidates to apply for a research grant. This will be able to support with the grants. And we have come up with a newsletter, and probably all the members will be getting it in a few days by email. And probably in the next newsletter, we are thinking of having more academic topics as well. So I request our president to suggest a few good topics so that we can get some good write-ups from senior faculty. And also, we can encourage our juniors also to participate.
Is Suri around? Anybody? Yeah? Suri?
Yeah.
Yeah. Great.
So there's a comment in the chat box. Many of the exam-going FNB arthroplasty trainees are also viewing this webinar. Today's webinar was very helpful. Thank you for appreciating. That's what we want. We want to be useful for all the DNBs and FNBs. That's why the entire senior faculty are here.
All top speakers are here.
Yeah.
So sir has got the other link.
Oh, okay. You want the participant link, huh?
Yeah.
Just invite you to be panelist.
Correct, the panelist. Correct, sir. Yeah, please. On the login. Logins.
Join webinar.
Yeah.
Okay. Am I okay now?
Yeah, you just joined now, sir. Yes, correct. You're done. You're done, sir. Perfect.
Hurry.
Hi.
I'll just... Sorry, phone on.
Yeah, off the phone, sir.
Yeah.
I think you are logged in two devices. Probably that's why it's echoing, sir.
Yeah, I'll have to
Log out the phone, sir. Yeah. We can see you now, sir. Yeah.
I can't see. Can you see the presentation now?
Not yet, sir.
Yes, sir. We can see you're logged in.
Is it correct?
Yes, sir. Yeah, you can share the screen now, sir.
Something wrong. Is it okay, Ashok?
Yes, sir. But screen not seen. So I can share the screen now. The down one. Raise the hand next to it.
Is it okay?
Screen is not seen, sir. We can see you, but share screen is.
Sound.
Yeah, mobile you can log out, sir.
My switching of the mobile. Yeah, I've powered off. I am not looking. This is the only device.
You don't see the share screen, sir. It's okay, sir.
It's not. I'm not able to get the share screen.
Because you're in the panelist only. You're in the panelist only. Poonam, can you help?
Anybody? No. I'm switched it off. No, nothing. I don't have anything. I'm not able to.
Or two windows will be open, sir. Two windows in the Zoom.
That's what I'm looking at. Now? Hello? Okay. I'll just. Is it okay now? I mean, audible now?
Yeah. Now it's the.
Yeah.
Okay. I know usually, but I can't see the share screen icon. Everything is there, but I'm not able to check. See.
No, sir, no. More, sometimes put in more.
More record apps, betting, share. Okay.
Yes, correct.
Yeah. Yeah.
Dhanshekar in Korea,
Can you see?
No, sir, still not.
Right. I don't know what I've goofed up here. Presentation is ready, open. I minimized it, that's all. Chat, now the share also is gone.
More option.
No, more one gone. That okay. I'm sharing desktop. Share. It wants to again do that in the open system setting. Okay. Okay, share. So I said I'm sharing on the desktop. Your open system setting and other things. Actually, it should not happen now. I think it should be sharing now. Am I?
Yes, yeah, got it, sir. Done.
I'm so sorry, everybody.
No,
Sorry. I don't know.
We had an interval now, so hello. Yes.
Okay. I think it's a late hour. Pradeep, I'm very sorry.
No, it's absolutely fine.
So I think thanks ISHK, thanks Ashok, the entire committee, the elders, Dr. Pachore, Dhanasekara, who has been doing some phenomenal work in the last years. My brief was to talk about exposure strategies and tibial tubercle osteotomy. This is probably one of the last things you would like to do at any time, but mind you, there are certain situations where you would probably need to keep this option open. Like Dr. Pachari was saying about the hip exposures, it is always better to have the added knowledge of various options to bail you out of many trouble. There are three major objectives when you have to expose. One is we have to be able to visualize the positioning landmarks. Number two, in the knees, in the revisions, in the difficult situations, get the patella out of the way so that you are able to appropriately size, more importantly, also rotate the components appropriately. This is very, very important. Third is to bring out the implants, especially in difficult revisions, or to get the tibia out of the femur or anterior to the femur. It is very, very important again to extract the old components. It is always better to extract the components in line with the point of insertion so that it becomes much easier. When you toggle it, I think you are in a danger of either damaging the bone, fracturing the bone, or losing probably the little bone that is available for refixation. The problem often in all the difficult exposures where you will need to consider a tibial tubercle osteotomy are the obliteration of total gutters, total stiff knees, prior procedures, prior interventions, post-infection, patella baja, where you are not able to flex the knee at all completely or very little flexion, and you will not get that level of exposure. Intra-articular fibrosis, sometimes the stiffness in extension, where you have the contracture of the quadriceps, and if patella is not mobile again, you need to loosen up all these tissues to access the knee adequately enough for you to get in the components. So these are the situations where you are forced to think of certain extensile measures. Because in all these conditions, you'll find that it's difficult to invert the patella, you're not able to translate, and in the process Often, if the bone is osteopenic, you have the patellar tendon peeling out, and that is a catastrophe to reattach the extensor mechanism. Always factor the previous scars when you do this. And when you have the vascularization in doubt, check with the Doppler about the dominant vessel. Make use of your plastic surgeons so that they're able to guide you into what is the appropriate way or what is the right way to approach, keeping the skin flaps safer. So I always make it a dictum that it is always better to work in tandem with your plastic team so that you get a good idea about the vascularized flaps which you can elevate with this. I always like to say this is what is called soften the flap first. Remember that the skin down to the bone, there are multiple layers you will need to separate. When you open a primary case, you know that once you take off the fat, then you have the galeal plexus or a galeal layer. You open up, then you come to the surface fascia. Once you open the fascia, you are looking at the quads tendon and the patellar tendon distally. So also it is important for the post-operative movement, there needs to be an interplanar guide between the subcutaneous tissue and the deep planes and the musculo-osseous planes. So once you have these planes mobile, then you are able to translate laterally either of the tissue planes, and that further augments your exposure. Something like a mobile window, which we call in the minimal invasive approaches. So that is what. So take your time in the initial exposure, work through the scar, take away all the flap tissues so that you've got multiple layers, useful also during your closure. So the primary extensile steps, most important is all the excision of all the scar tissue. Do not be very conservative in this. If you know, you need to understand the planes, and once you are familiar, excise the scar tissue. The proximal quadriceps, you can extend it linearly, extend the proximal extent of the incision. That again helps you to sort of lateralize the lateral flap. See if you are able to evert or sublux the patella. Oftentimes it will be very difficult. Don't do this as a first step like you do in the primary. You need to first mobilize, like I said, create the planes, take out the scar tissue, take out the adhesion to the bones, and then work on the parapatellar gutters, medially and laterally. This will be very, very necessary. If it has been a long standing between the previous procedures and the present procedure, you always find that this tissue is already epithelialized and you are able to force a good plane. Put your finger, if it is soft and supple, you can open up the whole thing so that your medial flap and the lateral flap is opened up. And once the gutters are free, you find you are able to translate the patella and probably evert the patella, not always. If it is a stiff knee in extension or if it is a long scarring and gross scarring, you will still need further work to do if you are not able to translate this. And what is important at this stage is always keep one eye on the patellar tendon, because avulsion of the patellar tendon is a catastrophe. The lateral side exposure is what is the problem. Medial side, you always get a decent exposure. But when you get the lateral side, you find that you're not able to get the patella off. So take out the proximal adhesions. Like I said, create the planes. Beware of the collateral ligaments, but work around, close the implants, take it out. And all the retropatellar scarring in the infrapatellar fat pad and the lateral patella should again seem to come out. Most common sort of extensile approach, we don't use some of this Kuhn's Adam and all. Very few people use this. But the commonest adopted is the quadriceps slide. This has a very minimal morbidity. And even in the primary situations, if your exposure is very tight, it is probably a good way to make it more extensile. This is widely adopted, pretty effective, and this is just a modification of the standard arthrotomy. I'm sure all of you are familiar. That is the way you just get an oblique line across the quadriceps tendon, about 3 to 4 centimeters proximal, draw an oblique line, and then just cut through both the rectus and the vastus intermedius if it is remaining. But in a difficult case, it is necessary also take away the vastus intermedius first, because that is another scar tissue. Once you do this, that is the vastus intermedius I'm taking out. You can cut enough for you to retract or expose. Always mark it both on the upper and the lower side. This is important for you to reattach this rectus snip as much as possible. Once you do that, you find the patella comes off completely easily. There are described procedures like Kuhn's Adams and the quadriceps turned down. But these all have a very delayed rehab, prolonged rehab, and quadriceps sort of a lag is constantly a problem. You may find some range of movement, but the functional range of motion may be difficult. So I think unless you're very, very familiar and you have had experience, probably the rectus snip is the best way to proceed. This is what I was saying, tibia anterior to the femur. This is the amount of exposure you need to get. Commonest difficult point is the posterolateral corner. So when you bring it in front completely, I think it becomes far superior because then you are able to take out completely. Unlike like you find if you are going to toggle the implant, there's always a danger they're going to use more bone. So for this reason, make sure first your exposure is complete and then you can proceed with this. Like I said, avoid the tubercle injury, lateral side quadriceps snip, anything you can do. You could transfix, but I often find that doesn't really help in terms of preventing an injury. What is important is more to take out the scar laterally. Sometimes, despite all this, it may be very difficult. Or right at the beginning, if you have a feel that the tissues are very tight, probably tibial tubercle osteotomy is a great approach to do. I know there is a lot of reluctance, there is all resistance, but we have been doing it in select situations over the years without much problem. It's a great exposure, very easy revision. It's a time-efficient process, minimal dissection of the quadriceps apparatus so that the secondary rehabilitation becomes much better. Some amount of proximalization may be possible that can augment your range of movement. The scarring is much less, and access to canals, both tibial and the femoral, I think it will be much easier in these situations, both for the removal and for the closure. So stiff knees, fixed deformities, revisions, post-trauma are commonly the reasons where probably you would use this. And there is enough data that there are people that in select situations it did very help. People reported complications. Of course, it is not without complications, but I can do, if you do it right, I think it is pretty much safe. This is just a case in about 4 minutes, which will summarize the whole thing. This was a primary fixation which had got infected, which is a processus in situ. Standard medial parapatellar. This is a planned tibial tubercle osteotomy. So you just go along medially, and then from the joint line, you mark about 1.5 to 2 centimeters proximal, converge over the medial shin of the tibia, so that it is broad at the proximal side, tends to get narrow. You could get a small sort of a transverse osteotomy distally for about 4 to 5 millimeters, or you could make it sharp. The advantage of taking it as a small transverse cut is refixation. The length of the osteotomy, about 6.5 to 7 centimeters. It could be a little longer, but don't make it very, very small. Once you have done this, you do no dissection for posteromedially or laterally. Right onto the bone, you just cut it straight. Then the proximal medial exposure slightly so that you get a control on the medial side of the flap. You don't do any dissection on the lateral side. You can now see the cement above. The ACL reconstruction saw blade is a useful tool. If there is a stem, you would hit the stem. Otherwise, you just go right partly into the canal. And you should have some idea about the thickness of the tibia at this level. You either drill multiple drill holes through the medial osteotomy, or you could straight run the saw, incomplete. What we do is, and then you just run the sharp osteotome. See, if you see distally, we have again raised a sort of a horizontal L flap. This completely takes out everything. Now you start removing all the lateral scar. Till now, we have not done that. I removed the spacer. Now we take out just the scar on the lateral side. And keep working close to the bone, all along the circumference from the anterolateral to the posterolateral margin. So this is what we call the circumtibial exposure. You get a 180-degree view of the tibia. Once you have this, you can take out all the implants, you can do your revision procedure, and then comes the issue of closure of the osteotomy. Sometimes if it is a stiff in extension, you will find that the tendon, the whole osteotomy zone tends to move a bit proximally. So be it, not a worry. Then you look at the intra-articular side. If you want, you may trim the bone proximally. Otherwise, we just temporarily fix it with 1 or 2 K-wires in different directions. Again, in the stem, you do what is called as a misanail technique. Go anteromedial to posterolateral, anteromedial to posteromedial, and preferably have 2 to 3 screws minimum, 3.5 millimeters full threaded cortical screws, along with a washer. The last screw should be at least 1.5 centimeters proximal to the distal tip of the osteotomy, otherwise it can tend to fracture this. One thing you can do before fixing is put your clamps, get the range of movement to about 90 and see what happens and assess to the osteotomy. These osteotomies will look like elevated. Some of them may not approximate well because of the stiffness, but over about 3 to 4 months, you find that they slowly settle down. But what is, of course, it is important that the bone quality should be very good when you do this. And this is a picture probably at about 5 to 6 months. I'm not sure of the time, but at that time it has sort of functionally healed and she is doing pretty good movement. And this was the picture. So the closure we said, like I said, the 3 closures with 3 screws, 2 proximal and 1 not above at least 1.5 centimeters. Otherwise, you will sort of flip the distal end of the osteotomy. So we just put it, just re-evaluating. You can either take 2 sutures or a patella clamp and then get the knee into flexion so that you get the range, how much. So now with just holding the patella, I'm trying to get the range of movement. The rest of the approximation of the flap will happen with your screws. So in a flexed position, you then put a couple of K-wires, it stays, and then one by one you can take out the K-wire, drill it, and then get your screws in. So this is the initial planning. And you have to see the medial and the lateral cortices. So when you put the screws, you stay intracortical. That will be ideal so that you don't hit the implant or the cement mantle. You can stay intracortical by just angulating the screw parallel to the medial shin or to the parallel to the lateral cortex. Once you do that, you always stay out of this and you get a real solid cortical fixation. The concerns, of course, are the local problems, osteotomy union, rehabilitation, or how to fix it. There are various methods, 5 Ethibond to cerclage wires to various ways. Personally, we have been using screws unless the picture was very tight. If in case you want to use the wires, it is suggested you get the wire before you put the stem, intramedullary, so that there is a solid anchor posteriorly and you can tighten it over the anterior tibial flap which you have created. Avoid this procedure at any cost when you have a big cavitary defects in the tibia, very soft bone or a poor bone stock and very thin cortices, because then you find it's a great challenge to reattach the whole thing and that can end up with a lot of catastrophic problems. Extended dissection time, I don't think there's much. In fact, you save a lot of time in the dissection and your surgical exposure becomes far faster. We have had experience, we have published this. The osteotomy union has been consistently predictable unless there are some interposing materials. But otherwise, fixation 2 to 3 screws. Healing, it takes about anywhere between 20 weeks to about 24 weeks to see a radiological healing. A certain early lag, it may persist. Full resolution will take about 4 to 5 months in these difficult cases. Thank you.
Thanks, sir, for this excellent TTO elaborate presentation. Any questions, Pachori, sir?
Suri?
Tell me, Pachori.
We have been using actually white sides wire technique actually, because these screws, these are usually osteoporotic bones, Suri, most of the time, which we
totally agree.
situation. it tries to split that portion, So that's why we are a little
skeptical.
use the wires, what has been described by your white side.
I know. That's why the other one, which has been also reported, using just a 5 ethibond, no metallic thing.
I know.
He has published, who has come for the Ganga course also. So, I mean, the fixation, I think we have to take a decision, take a call based upon the bone quality. Very important. It also depends upon the thickness of the osteotomy.
Osteotomy, yes.
Yeah.
No, you've done a beautiful video. There's no question about it. How preserve the lateral structure, very important. Like how we do a transfemoral, the whole muscular soft tissue has to be preserved. So that's why you don't do anything laterally. You just put only 2 spikes to protect the lateral structure.
Yeah, I think
how suicide does is a multi-directional screws, 3 screws, multi-directional. Yeah, miss the step. Yeah.
Suri said very good. Use intracortical screws.
Yeah.
Sir, can you stop sharing so that we can see you?
Yeah.
Have you tried, Suri, reverse cordyceps snip?
No.
Okay. That has been also described in the literature.
The other question that comes is, suppose we find that we did a quadriceps snip already, which has happened to us on 3 occasions, at least to my remembrance. Can you do a tibial tubercle osteotomy? The simple answer is yes.
Yes, why not?
It doesn't matter at all. Bhosale, any your tips?
Yeah, I think if you do it correctly, preserve the lateral hinge, and the closure is preoperatively planned so that before osteotomy, make the hole, make the marking, so you know exactly flat. And sometimes I also make a drill holes, like Dr. Pachore says, and you make the drill holes before doing the osteotomy so that it matches correctly.
After some time, it's impatience.
Yes.
First 10 cases, you did everything. Later on, you straight away take the saw and get on with it.
Yeah.
But I think as a teaching thing, it's always good to put the drills. You are correct.
So screw and wire, many times I've used both also. And I think it's a wonderful technique to get a good exposure for stiff in extension. It's required,
See, this
is cases, as you said, you can do both. You try first with the sniff, and it is not possible. You can.
I think everybody should be aware of it, that it is not such a difficult thing, and they should know the finer nuances.
Wonderful.
The surgeon you mentioned is Dr. Reddy and Morgan Jones.
Reddy, yes. Reddy published it.
Yeah, he routinely does osteotomy for all his revisions. It's a small limited osteotomy only for the exposure. So straight away does the osteotomy, then he opens up and the job is finished really fast.
I think Reddy does a lot of challenging, difficult situations. So probably he needs that more often.
Yeah. I think thanks, Pachuri sir, Nish giving this opportunity, and Bhosale sir, and Secretary Dhanasekara having the educational meeting. So we'll do better next time again. Yeah.
So when is the next
Ashok and all of you, you should not thank ISHK. You are a part of the ISHK.
Yeah, no. It's always a platform given. So I think we should utilize it right for the people, right cause. Yeah.
So Ashok, when is the next meeting?
Yeah, next month we'll send it. Tomorrow it will finalize.
Okay.
Thank you very much. Wonderful meeting and well organized.
Thanks, everyone. Pradeep, you need to talk. Yeah, Pachore, you're not picking up the phone.
Sir, the other way, no. See, the other way, no.
Yeah.
We have to talk about some points, Pradeep, also.
Yeah.
We'll have a meeting online.
Sure. It's late night for Suri. Thank you, Suri.
No. Sorry, I'm just coming out of some sort of viral chest. Adding a cough to it a bit.
Weather is very unpredictable.
God knows it doesn't take much for me to get that.
I know. So take care, Suri. Good night.
Thank you. Thanks. Thanks. Yeah.
Thank you.
Good night.
Well,
Good night. Good night, everybody.
Yeah. Thanks, Dhansh.
Thanks, Ashok.
Thanks.
Thank you, Ashok. Wonderful organization. And Dhan is doing also a fantastic job.
Yeah.
Thank you, all of you. Thank you.
Recording stopped.